we're very fortunate to have three fantastic speakers with us: Sara Dada, Dr. Norma Tsotsi, and Jauhara Nanyonda from Uganda, coming in to talk about their experiences in Ebola research and the ethics of doing this work in a global pandemic. So we are waiting for one of our speakers, but you know, I think, again, given the timing, we can go ahead and get started. We hope this to be a participatory discussion and engagement at the end. You'll see in the chat feature, we want you to share your experiences. While we have experts here, we know that many of you on the line are also experts. So we really encourage you to share your experiences in the chat feature and use that Q&A box to help us develop a question and answer document that we can circulate to you, so that we have a resource after this on what are the things that people want to know about and how to do this work. So we really encourage you to ask lots of questions and go ahead and we can get started. So Melissa, I'll kick it off. I'll hand it over to you.
Yeah. Hi, Jessica. Thank you so much. Dr. Norma's here. She is on the participants list. If you can help, or you or Levi, get her onto the panelist list.
Yes.
Yeah. Okay. So hello, everyone, and welcome to our webinar on conducting community engagement during a public health emergency, lessons learned from the Ebola response. As Jessica has already said, my name is Miliswa Magonga. I'm from Vetarish I. We are so excited to have you join us today. I hope all of you are well and are keeping safe under the circumstances. I think Jessica has gone through the house rules already, but I can just go through them again. The webinar will be recorded and it will be shared widely. And there will be a dedicated time for a Q&A at the end of the presentations. Jessica and I may take one or two questions immediately after our panelists have presented, but ideally we just want to save the majority of the questions for the end. So feel free to type any questions, any comments. Please share your experiences as well in the chat box. The aim of this webinar is to not only contribute to a global discussion on effective COVID-19 response strategies, but we were just also trying to provide a platform for us to discuss opportunities and challenges of engaging with our communities during a pandemic. So our panelists, as Jessica has already mentioned, will share their experiences of conducting stakeholder engagement during the Ebola crisis in West Africa. They'll share some of the lessons that they've learned that can be applied today in the current COVID-19 pandemic. We also have one of our panelists who will explore some of the ethical challenges to conducting research during a pandemic. So while we recognize that Ebola and COVID-19 are different in so many ways, they present different challenges and solutions that might work in one country or region, but might not work in another one. But we also believe that there are some community engagement principles and lessons that we can all learn and apply in our different contexts. So we will start our webinar with a presentation by Sara Dada, who will be sharing her community engagement experience from Ebola vaccine trials in Sierra Leone, followed by Dr. Norma Tsotsi from the University of Witwatersrand, who will share on the ethical implications of community engagement during a public health emergency. And then we will be joined by Jauhara Nanyonda from Uganda, who will, based on her experience in Ebola preparedness, will shed some light on the role which community engagement managers and officers can play in preparing for a public health emergency. And on the call, we also have community engagement officers and managers from all over sub-Saharan Africa, who will at the end also share their experiences and challenges in community engagement during a pandemic. We know that, for instance, some sites are about to open up and start recruitment amid COVID-19. Some staff are a bit anxious about that. And so we are looking forward to a really robust discussion at the end on this. So over to you, Sarah.
Thank you so much, Melissa. And good morning and good afternoon, everyone. Thank you so much for joining us. I'm very excited to be here. My name is Sara Dada, and I'm currently a global health researcher at the Value Global Health Foundation in Boston, where I work in clinical implementation and also communications, and I think engagement is a part of all of that. My background is largely in communications and community engagement, and particularly around these vaccine trials that we're going to speak about, and vaccine sentiment. And so many of the examples will come from that today. Next slide. To give you a brief overview of what we're going to talk about in the next 15 or so minutes, I'll share some experiences from the Ebola vaccine trials that began during the West Africa outbreak and continued through the DRC outbreaks. We'll cover a few tools and strategies for engagement and summarize some of those main takeaways that can be useful in future research. Next slide. Before we delve into how to engage, it's important to consider what happens when we don't engage. Next slide. This video is about controversies around potential Ebola vaccine trials in Ghana. We'll start it now.
Is rising in West Africa. The scourge from Ebola shows no signs of stopping.
The fear and mistrust took a violent turn in Liberia's capital, Monrovia. An angry crowd, many of them armed with clubs, raided an Ebola isolation ward in the city's largest slum.
It's a process that usually takes years, but in the race to beat the Ebola epidemic, doctors and scientists
Jessica, if you unmute, I think we'll still have the sound.
However, we've never had a trial as sensitive virus as the Ebola virus. Because mind you, we're coming from a backdrop where Ebola had killed, between Sierra Leone, Liberia, and Guinea, had killed almost 11,000 people within that short space of time. So there was so much fear in the system.
It was meant to kill people. That was the news going around.
What were you going to use as the vaccine? Is it an Ebola vaccine or is it another vaccine? What is it? What is the component of the vaccine you're going to use?
People felt like this thing was being done undercover.
Why Ghana? Wouldn't it involve bringing a virus to Ghana before you start? Did you know the difference between the virus and the vaccine? Do we have the systems? Do we even know how to register trials? Have people been paid a bribe to undertake this trial? Are these scientists taking us for a ride? Where is our regulator? All these questions were asked.
So the whole society was up in arms.
It wasn't a case of the laboratories or the ability to go about the test. It had to do with the issue of fear.
Thank you for that. I'm glad the video worked. And hopefully, as you could see, Ebola had this reputation. And when rumors about a clinical research trial coming to these communities were mismanaged by the media, that fear spread. And unfortunately, in Ghana, the damage was done before the trials could even roll out and get off the ground. But this discourse, this mistrust and fear around this epidemic and subsequent vaccine trials and other response programs were a constant theme and something we continue to see in other epidemics and pandemics as well. So in order to engage, it's important that we listen. And in the age of growing technologies and online communities, there are cases where we can leverage online media and social listening platforms. So let's walk through how this can work. Next slide, please. Social listening tools can be used by developing keyword searches that can then search the internet, pulling from social media forums or online news articles, which can be seen here. This slide is an example of a search strategy that was used to look into the Ebola vaccine trials that were set to begin in Uganda last year. We looked at Ebola and any mention of vaccine or trial, as well as the region that we were looking at. Next slide, please. We can track the volume of activity as well as the levels of engagement across platforms and online. Next slide. And these tools and other simple analyses can also be used to highlight some of the main topics of conversations and frequent discussions or controversies even, as can be seen in this word cloud, as well as other analyses that link some of those topics together, such as a network analysis that shows the common threads between the different discussions. Next slide, please. And interestingly, on social media forums such as Twitter, there are other things that we can look at to understand what a conversation is about, or to really understand the nuance of a message, such as hashtags and emojis. These can sometimes completely change the meaning of a message by providing some insight into sarcasm or other nuanced language rhetorics. So for example, on this slide, this is a list of emojis that came up in that Ebola vaccine trial search in July and August in Uganda. And these emojis can provide some interesting insight and completely change the meaning of a message in some cases. Many of them are neutral, such as these pointing fingers or arrows, and even the microscope, but some of them might provide some more information, such as this quizzical or skeptical face, as well as this bomb that would probably intonate something a bit more dangerous or something negative. So we can click on these and understand what context and what messages were sent with these emojis used. Next slide, please. Now, beyond online tools, which can be useful in getting a pulse on public perception and sentiment, how do we integrate community engagement programming in the field, and why is this important? In this last section, we're going to take a look at the Ebovac-Salone and Prevac trials in Sierra Leone. So Ebovac-Salone was rolled out in Cambia, Sierra Leone, while the outbreak was still ongoing in 2015 and continued for a number of years afterwards. Some of the challenges that they faced were rumors, establishing trust, and understanding power. So for example, some of these rumors, Ebovac sounded to some people like Ebola back, or Ebola is coming back. So some of the rumors that also came up in that Ghana video were that they were bringing Ebola back into the communities. Another rumor that was common throughout the outbreak was that blood was being sold to international blood banks. And as a final example, a new rumor throughout the trial was that it was a form of population control because they were requiring participants to use contraception if they were also participating in receiving the experimental vaccine. Other challenges came from establishing and understanding trust between the trial and partners and stakeholders in the public. The context of Sierra Leone, such as a recent history of conflict, common government corruption, and gaps in healthcare system, in addition to this community being a research naive setting, all influenced this relationship between the trial and the community and the perceptions they had of each other. And finally, trial staff needed to understand and respect power. This is where some of the ethical questions in terms of research during an emergency also come into play. Who makes the decisions? Who receives a vaccine or treatment if it's available? And finally, we also have to understand the local dynamics and power structures in order to work within them and demonstrate that respect in order to get that local acceptance as well. Next slide, please. So as a component of addressing some of these challenges, Ebovac-Salone and later the Prevac trials in another neighboring community in Sierra Leone implemented this interdisciplinary community engagement program. So in this structure, they had two teams that went out to the communities. That was the community liaison team and the social science team. The community liaison team would hold big community meetings, small events, town halls, where they would publicize the trial. They would try to recruit participants, and they would establish relationships with the community in that way. The social science team would also go out to the community, and they would speak with smaller groups of people in order to gather some of the concerns, the rumors, and the misconceptions that people had of the trial or from the meetings that they attended. And they would report this back to the community liaison team, as well as the rest of the clinic, so that they could adapt and make changes based on that feedback. So for example, when the social science team picked up on those rumors about selling blood, the community liaison team started bringing test tubes with them to the community meetings that had the amount of blood that was taken in a blood sample, and they would fill them with water, and they would dump them into their hands or into the hands of participants to demonstrate to them the small volume of water that was being, or the small volume of blood that was being taken for the experiment or for the trials. What was really important about this structure is that it allowed the trial to adapt and make changes and to demonstrate that this was engagement. This was a partnership between the community and the trial, not just one-sided, one-off conversations that didn't go anywhere. Next slide, please. So while observing this community engagement program across the 2 trials in 2 districts in Sierra Leone, I noticed 4 characteristics that were common themes in the success stories that were shared with me. I now want to share these 4 R's with all of you. A vital component of community engagement or engagement is that it's a 2-way street. It's reciprocal. In the early days of the Ebola response, the focus on messaging was sensitization and one-sided instruction and directions of what to do rather than a conversation or addressing real-time concerns. Community liaisons explained that they kept team meetings or community meetings engaging and involved by not only answering the questions that were asked of them, but also by posing questions to the public that they met with, and to really engage in a conversation and a back and forth, and to keep them involved throughout the meeting. Another important characteristic was being relatable. In particular, considering this research-naive setting, it was important that trial staff use not only the appropriate local language or dialects or even slang, but to also use examples that made sense, to use metaphors and stories that were digestible and could be easily relatable. One of my favorite examples on this was when staff were asked why they were not participating in the trial, why they weren't receiving the vaccine. They gave them the scenario of a football game and said, in a football match, you can't be the referee and play the game at the same time. And this was such a brilliant and simple way to describe conflict of interest. Third, and an unsurprising yet, of course, crucial factor was respect. This respect was important when starting the trials from the very beginning because they needed to respect the local power structures and dynamics and hierarchies in order to get that buy-in from the stakeholders. And by getting that approval and getting that kind of endorsement from local leaders, that opened many doors into the community and also demonstrated that they really understood and wanted to work with this community as opposed to just coming in from a top-down approach. Community members, what was interesting here was that community members explained that this respect was also two-sided. They said that the staff members had shown them respect, and so they, of course, wanted to share their respect in return. And finally, a factor that was paramount in the trials was the strength of relationships. This came up time and time again. Nearly everyone expressed the strong shared values in family and friends and would talk to each other and describe others as their aunts and uncles, their brothers and sisters, their grandmothers and grandfathers. And this also fed into the respect a bit as well. Many used this language about valuing their fellow neighbors, and they explained that this relationship, the fact that they were known, the fact that they were like family, is what allowed them to trust the trial staff that were coming in. As this great quote puts it, they say that brothers and sisters always bring good things for each other, so that's why when I see them, I was always ready to listen. Next slide, please. Finally, to summarize some of those main takeaways in designing and incorporating community engagement in your programming in a public health emergency, or during a public health emergency, an interdisciplinary approach that includes clinicians, anthropologists, epidemiologists, and others allows us to bring in these different perspectives and craft the most holistic community engagement approach that you otherwise might have missed if you weren't incorporating all these perspectives. Second, communications and community engagement should not be an afterthought. It's so important that we include these strategies before, during, and even at the end of an intervention. That last part, or a research program, that last part about the end is so important because it demonstrates not only this respect for the time and buy-in from the community, but it shows them the impact of the work that they had and the behaviors and the actions that they took. And it's so important to keep that relationship going beyond the time that you're in that context. And finally, don't just shout louder. Effective communications isn't just about speaking, it's also about listening and engagement with both sides. That's all I have for today. Thank you so much for your time, and I look forward to the rest of our discussion.
Thank you so much, Sara. We do have time for one quick question. You know, you shared a great example about monitoring social media and checking sort of search engines, but not everybody has that ability to sort of monitor communication online. Is there a way to monitor community activity without using social media strategies, or is there a way to get those perceptions without using that kind of technology?
Yeah, that's a great question. One of the things that I was struck by in Sierra Leone was the constant use of WhatsApp communities still, and that people outside of the WhatsApp communities would still talk about and hear about those perceptions. So I think when you can't do this kind of online big picture approach of understanding what those conversations are, the next and what really might be the best thing is to have those conversations in person. So to have some sort of structure or opportunity for going out and speaking with community members, or for the public to be able to speak with you and provide feedback, and to kind of be able to get a pulse on the different opinions and perceptions that are going on. So I think definitely beyond online, in person is so important.
Yeah. And somebody just wrote, you know, this, it's a testament, right, to the importance of community engagement and communication, and that relationship is so strong. Thank you.
Absolutely.
We will definitely have some more questions for you at the end, but we do want to move on to Dr. Norma Tsotsi from WITS RHI to take us through some of the ethical considerations. Dr. Norma, Dr. Tsotsi, are you able to speak? Dr. Tsotsi?
Can you hear me?
Hi, great. So over.
Can you hear me?
Yes, we can hear you.
Okay.
So go ahead.
Where's my presentation, maybe? Okay. I think some of the issues that I've raised in this presentation have been raised by the previous speaker, but I'll just summarize them on what community engagement is in research and in pandemics. Next slide, please. Well, as all of us know, that community engagement presupposes that there's an agenda at hand, which needs communities buy-in as a potential change agents, because communities are change agents themselves. So we know that the goal of public health is to benefit the population, to prevent or reduce harm. Weighing these ethical issues consideration is not easy. In public health pandemics, communities are key to successful and effectiveness of public health strategies. So community engagement is a potential of increasing the public's understanding about the pandemic, and could lay the platform for communities to voice their priorities. Next slide. So I think I like how Carson explains community engagement. He says, what interests me as a researcher, a consultant, an advocate, and a teacher is community engagement that is not tokenistic. It's not a token. It is not simply about sharing information or listening to opinions via a survey or focus group. It is about partnership with communities to engage them in joint decision making. Inevitably, this leads to empowerment which is not something that can be given to a community, but something that can emerge when conditions are conducive to its emergence. Next slide, please. Community engagement is not only a public health imperative, but it's an ethical requirement as well. Thus, there is a need to establish an inclusive community engagement framework, which is guided by ethical principles. Next slide, please. So our question is, how should communities be involved in promotion, prevention, and research? Is it feasible in the context of the continent or South Africa? Do we have enough resources and know-how? How do we deal with cultural and racial issues? And communicate with those who are privileged, because South Africa is a divided society. There are minorities that are powerful and very rich and have the biggest voice, and the majorities who are very poor, but they don't have the voice the voice to talk about their concerns. That is what here in South Africa we have to look at, how to engage in this divided society. As Taomi said, we have two economies mingled together. One down, please. Next. Remember that we're talking in South Africa about a vulnerable group. There's limited development, I think this was raised, and mismanagement. Inadequate protection of human rights and discrimination on basis of health status or gender. Our communities have all their own cultural experiences of understanding scientific research and limited ability of individuals. I mean, there's no illiteracy. Next. And I think this is not just common to South Africa. We have what we call differential vulnerability in the developing countries. It's where the pressure, individuals or communities are under pressure of researchers or doctors, either to participate in the research or let their children participate in research. And because people don't have this education, they tend to defer to authority. That's exactly what I mean when you come from this background. Next slide. So we all know who is vulnerable and why we're so concerned. Because we're concerned because such people are susceptible to exploitation. There's this unequal power relationship of the researcher who seems to know it all, and the communities that are just seem to be blank, not knowing what is happening about this COVID-19. And there's all that dependency that maybe the doctor or the researcher knows that, and that erodes the voluntariness to participate or to be part of the research team. Next one. Can you hear me? No hearing here. I'm lost.
Dr. Tsotsi, your sound is a little off. Is there any way that you could just get a little bit closer to your microphone?
She's muted.
Oh, there you go. You're unmuted now.
Please unmute her, Jess. She's muted now.
She has to unmute herself.
Oh.
I've done that.
There you go.
Can you hear me?
Yes, we can hear you.
Okay. Let's look at the ethical and social implications of this pandemic in research. I think you have all heard about the stigmatization of people who have been found to be positive, and a lot of confidentiality and pre-resistance transgressions. More importantly to me is this disease profiling of knowing that people come from certain areas. For example, in South Africa, if you come from Johannesburg, from Gauteng, or you come from Cape Town, you are profiled automatically that you come from a high-risk area. And of course, the whole issue of people coming in and out of the country in issues of immigration selection. This is one of the biggest issues about COVID-19. Can you hear me?
Yes, we can hear you.
Now I see your faces look lost. I'm looking at your faces as an indicator. So I've spoken about vulnerability, which is within our ethics in health research principle. This is a guidance document which talks about the issue of what we should look at when we're looking at vulnerable groups. So when you're writing your protocol to the research ethics committee, you need to say how will you address this vulnerability. Next slide. I'm saying here, community engagement without ethical principles guiding the engagement is not moral. And community engagement, though very time-consuming, is morally justified. The next one, please. Remember that it comes from different worldviews. We have people who believe in God, others believe in cosmology, others believe in the Bible, and others think it's a myth. There are certain norms and that we have to look at ethics and morality, which is different. Morality and ethics are different, but I won't go into that. There are certain rituals that people look. So the worldviews that we come from are very different in the context of South Africa. The next one. I like this quote because when we're doing research and engaging with communities, this is what we should always look at, is that the world in which you were born in is just a model of reality. Other cultures are not failed attempts at being like you. They are unique manifestation of the human spirit. Next. So there's an ethical imperative to conduct research during public health emergencies, as some research questions can be adequately investigated only in emergencies. Next slide. As we've discovered, routinely in public health, scientific considerations blend with political and ethical conflicts and questions of autonomy, individual rights, cohesion, justice, community, the common good, the norms of research, and multicultural values are central. Next slide. Of course, we can't say that we cannot carry out research because of the problems that we have with COVID. And there's a justification for carrying research in vulnerable groups. As long as the research could not be carried out as well with non-vulnerable groups, and the problem is related to vulnerability, there is without. Okay, I can't say, you can't hear what I'm saying, unfortunately. Next slide. Next slide. So here's some of the links that the group harms that can happen, and social vulnerability. People can be stereotyped, discriminated against, they can be victimized socially, and of course, because they have COVID-19, they're infected with the virus, because that vulnerability of being dissimilar, you are not the same as other people who are in your community. And we have to think about these issues as we carry out research in communities, engage communities. And the next slide. And we must really be careful of these group harms because people might distrust healthcare. There could be psychological disruptions of group values, fostering of discrimination, loss of economic status by the community, and legal public determination. Next slide, sorry. Therefore, increasing knowledge and understanding of difficult issues surrounding research in pandemics involving vulnerable groups and group arms results in establishing a healthy balance between protecting the interests of the vulnerable and valuably expanding the research base in areas of care which serve them. Come, next slide. Hi. What is the value of this research to individuals? Will the participant be fully informed about the research? Do the benefits of the research outweigh the risks? Can participants volunteer to participate in the research without declaration? Is the research in the interest of the participant? Next slide.
Dr. Norma, if you could also just speak up a bit, people are having difficulty hearing you.
Yeah, I don't know because, what do I say? I had a meeting the whole morning and nothing like this happened. So,
I
think I should do.
Go ahead, Dr. Norma.
She is, you are muted. Please unmute yourself, Dr. Norma.
Yeah, but I can't see the slide.
Okay. Can you see the slide?
For areas for protection.
I can't see the slide. I can't see the slides that I'm talking to.
Oh, okay. Okay, we will just do our best to, apologies for the connectivity issues today, but we will everyone, yes. To just finish out the presentation, and we will make sure that we send around the slides to everybody.
Yes, that's fine. But I can't see the slide.
So we are on areas for protection.
Yes, I can't see the slide.
Can others see the slides?
I can see the slides.
I can't.
I can see the slides.
Okay.
Or maybe in the meantime, while we sort out the technical glitches, maybe we can move on to Zhao, because I'm also looking at the time. We have quite a few we have quite a few interesting questions that have been asked on the chat that I think it will be nice if we can address during the webinar. So maybe while we are trying to sort out the technical glitches, Zhao, please go ahead and make start your presentation.
Hi, Jauhara. Jauhara is a community engagement manager from the Makerere University in Uganda, and has done this Ebola preparedness research. It's going to talk about the lessons learned. So go ahead, Jau.
I'm grateful that my internet does not end up as Dr. Norma's. So good afternoon, good morning, good evening, everyone on the call. Okay, so it's really about stakeholder engagement or community engagement, and the two previous speakers have talked about the definitions of community engagement, but I must say that community engagement has diverse definitions, but the key issues that need to come out in the definition is really highlighting that it is a process. It is not a one-time activity, and there has to be the effort to build a relationship. That's very important, and working together with the different stakeholders so that you're able to achieve and promote the well-being of people. There are several definitions, and I was able to quote just one of the so many, and I quoted the most recent that I could find. Next. The need to design an emergency community engagement plan. So during public health emergencies, I'll use the Ebola experience. We need to develop community engagement plans. And when you're developing those plans, there are things that you want to achieve. I think I need to increase the size of my slide on my end. Okay, so we need to achieve, as you develop this, the CE plan, as I'm going to continue calling it, other than completing it, we need to have a shared assessment and analysis of the situation. We need to design context-specific approaches, and here we mean, for example, if Ebola is in Congo and it is in Ituri in Congo, please don't sit in Kampala and develop the plan and take it to Congo. Go sit with the Congo people, specifically in that community. There are people who will be who will help you develop that strategy because they understand the context better than you. People who are at the center, they know the area, they know who is most vulnerable. But if we sit somewhere in Kampala, because that is my capital city, and develop a strategy and take it to, say, 500 kilometers away from where you develop the plan, it might not be able to work. Then defining the roles and responsibilities. So if you develop the plan, from within the community which is affected, you'll be able to be inclusive in a manner that you're going to bring several people on board, and they will all know their responsibilities, and they will fight the problem. In the context, this context, it's the Ebola. Implementation of the strategy, and that makes the strategy implementation process very easy because everyone knows their responsibility. And the contrary to that, if you have to bring the strategy drawn in Kampala and bring it in, say, Kasese, you'll be bringing a stranger at that time. It's a strange plan, and you want people to fit in. Other than if you had developed it in Kasese, for example, people will actually from the start know where they fit in and how to move the implementation faster. If I can quote some of the voices that we have had, and I am sure other people on this call who are experts in this have had such voices where people say, that is not that's not our business. That is the business of the Ministry of Health. They'll come here, they'll bring their big cars and their teams, and they'll have that sorted. And such voices cannot make a public health emergency intervention successful. Rapid evaluation to inform replanning. So in emergencies, there is a tendency of things being done very fast. And what needs to be included in the first processes is the rapid evaluation to see whether what plans you have devised or whatever the intervention you have developed works, and if it doesn't work, you convene, you discuss, and see how you can make that, you can improve, and then you provide an intervention that works in such a situation. Slide. This is really a continuum or a flow of the different ways of community engagement, and it has to be done as it is, as in all the blocks need to be achieved. If you do one of them, you might fail to get the impact or the benefit that you want to get. If you do say just an outreach, you may fail to get the real community engagement that you would have wanted in terms of the benefit that you want to achieve. And the benefit of all this is really to increase trust with the communities, increase their involvement, their communication, and the impact of the program that you're bringing on board. So at different levels, different contexts, you need to try and try to achieve all the 5 blocks. Next. The relevance of community engagement in public health emergencies. Why do we want to have community engagement? The previous speakers talked about the same. It's really to increase the level of trust. You want to elicit community involvement. You want to facilitate communication between stakeholders, and you want the stakeholders to uptake and take up the innovations that you're working up to. There is several evidences that has been documented, and the first one I can quickly highlight is the one Sara shared on this same webinar. The problem that came up in Ghana when there was not good engagement. That is now the fastest that we can talk about. So if you want to have trust, you want people to believe in whatever you're talking about, please involve them, discuss with them, involve them, help them make decisions, support them along the way, and then eventually you will have a good plan. The last red lines, sometimes we see people not buying into public health emergency community engagement plan. For example, let's say Ebola. I want to take the example of Africa as one country, and if Ebola was in, say, in the eastern part of Africa, and that's just part of the big continent, and if people sit somewhere and develop the plan and come into Africa, in East Africa, and bring it up, technical teams or public health experts, excluding the social scientists. These are most times are usually medical people, because they want to bring on board the epidemiology. They want to study how the disease transforms and how will the people get affected. Most times they forget about the social scientists and the general community that is affected, and they tend to develop models that people will follow in terms of intervening. And this most times we tend to lose out because why they want to sit and do it themselves, technical people, because emergencies tend to be very fatal. So they want to fast. So they tend to forget other players in the whole continuum. And then because we are poor, some countries don't have resources, so they tend to say, okay, so because we don't have a lot of money, we may not want to go and engage every stakeholder, and then that ends up affecting the community engagement efforts that one would have wished to have. And then there is also competing priorities. Depending on who is ranking the priorities, you might find that community engagement is not one of those that is ranked highly. Next slide. So I have done some work in Ebola trials and Ebola preparedness work. So for example, in 2009, when we first conducted a clinical trial for Ebola in Uganda, the whole team thought that that trial couldn't happen because Ebola was seen as a monster that kills. It is very fatal. And it is not, then it wasn't a big thing in our country. So why do we go for Ebola other than HIV? HIV is killing more people, malaria is killing more people. So why do you bring Ebola vaccines in the country? So there was a lot of intensive engagement at different levels. From community to the high level meaning the Ministry of Health and its relevant departments, the different public health authorities in the area where the trial was conducted. We had around the research site, there were medical schools and medical schools, training schools really for medical students. So we made sure that we engage all those stakeholders so that they can appreciate the need to have an Ebola trial in the effort to prepare a vaccine available. In future, if we are attacked, then we'll have a vaccine in store to take on. So that context was in Kampala. And then for the preparedness efforts, they were far away from Kampala. They were really at the borderline of Congo, and we know that Congo is one of those areas that are affected by Ebola. It has had several attacks. So when Congo has an outbreak, the borderline districts tend to have a lot of intensive preparedness, response, and management efforts beefed up at the borderline. So we're able to support, and some of the things that we learned during the preparedness for community engagement. Next slide.
So Joe, we are running close to the hour and we do want to ask questions, so we do need to wrap up in just the next minute or two.
Yeah, I think this is the last slide. Some of the things that we learned from the preparedness for the Ebola efforts is one, several people have talked about it, the ownership. We need to have community engagement plans that are owned by the community itself, because it allows leveraging on community resources in terms of facilities and human resource specific innovations. Communities can find solutions during the planning and the discussions, and those solutions are relatable to them. They know how they can work through those solutions, work through community structures that are existing. And then what we learned is that we can't have a one size fits it all community engagement plan. That how it was developed for Karamoja, you just pick it up and throw it in say Zimbabwe, and it works. You need to tailor the plans. And then we have recently known that it's actually not a recent practice, but history has documented it, that the army or the armed forces deployed or utilized to support public health emergencies. But we learned that process, that intervention where you have the army deployed and engaged is not sustainable, because you're bringing people into the community, and after it comes down, you will take them away. So there will be people will work towards probably complying to the law because the army is enforcing, but then it will not be their own. So eventually when the army leaves, it will be business as normal. Next. Yeah, I think that's it. Those are the references I was able to read to about, and then those are really acknowledgements to the communities and the network, and people who gave me the platform to come and share my experience. Thank you.
Thank you so much. Thank you so much, Zhao, for such a wonderful presentation. I am conscious of the time, but there are some very good and important questions that have been asked on the charts that I think we can just throw to the panel. One of them is that because of the rapid speed at which research is conducted during a public health emergency, there is usually no time to do a plan, or even if you do a plan, but things change rapidly. So how do you ensure that communities, including the most hard to reach and vulnerable populations, have a voice and are part of the response? Sarah, you can come in here as well.
I can start. I think one, that's a great point and a great question. It definitely poses a unique challenge when you're working in a health emergency setting as opposed to maybe general research. But I think one thing that can be done that might mitigate that, or might be one tool to help, is the inclusion of local staff in your research programming, or and specifically in your kind of engagement aspect. If you go in valuing that community engagement is going to be an important part of your program and of your project, and you keep that in mind, and you include local staff as part of the team, then they will have that insight automatically, and they'll know different scenarios, or they'll know some of the nuance that needs to be kept in mind, and ways to maybe maneuver some of the quick changes that need to happen. So I think that's what I would suggest as one thing to keep in mind.
Okay. Zhao, do you have anything to add?
Zhao, you're muted. There you go.
Yeah, I think as these emergencies are identified, and scientists want to do research, there are existing structures that are already in place. Even, for example, now we are all affected by COVID, but there are structures that were existing before COVID came in place. So probably tapping into those could be useful, because they've known research before. They know how the modalities are, bringing them on board quickly, and orienting them, and giving them information about COVID, and see how they can support the process in the interest of the community, I think would be a good option.
Yes, so thank you. And another important question is that of fake rumors and fake news that circulate, especially on social media during public health emergency. We've seen that in Ebola. We are seeing it even now during COVID-19. So how can communication be improved to actually stem out the spread of misinformation, and to improve public understanding during this time?
I think, let me take it first. I think that the issue of being trusted is very important. So if institutions build a history of being trusted by the public, is very important. That, for example, now that COVID is available and there is so much rumor that is going on, there is they are mandated institutions that we know should give us have the authority to give us the communication. So such institutions need to be at the at their toes in terms of responding to such misinformation that comes up. They should be it should be timely. The authority needs to speak, and they should always come out and demystify such communication. But there is a lot of trust that needs to be built so that the public believes that yes, if we get information from Sara about COVID, that is the source. And even when they hear from X, Y, and Z, they'll refer to Sara. And if Sara is available and able to give information and correct up what is wrong out there, I think that will be helpful.
Absolutely want to re-emphasize all of that. I think that trust is very important, and I think also the authority figures have to respond to the questions and the concerns or the rumors that are coming up. They can't be ignored, because that they'll continue to kind of fuel on the side and gain ground. And so we need to use strategies that address the challenges that are actually being faced, that address some of the misconceptions or the confusions and concerns that people have, and do that in ways that are respectful, that are engaging, that are innovative. I've seen some really interesting cartoons or different videos that WHO and other authorities have shared that I see gaining some ground. It's definitely a big challenge in today's fake news environment, where a lot of these kind of conspiracy sites actually get a lot more, even if there's fewer of them, they get a lot more engagement and they gain ground very quickly. It's very easy for kind of salacious news to spread. And so we need to strengthen those authoritative presences by developing that trust with the audience and the public, and by answering the concerns that they do have in real time, rather than kind of this very diplomatic approach, I think is important.
So, well, I do just want to raise one last question, because I do recognize time, but somebody asked a really great point, and it's sort of the theme of several questions. How do you, if you don't already have a team in place, a lot of this is in research naive areas and places that haven't seen this before. How do you actually build these teams which don't have the trust necessarily in the community in real time? And Sara, you had put up that great diagram of sort of the social scientists talking to the community, talking to participants. And I think that's where this question is really coming from. It's how do you build that network at the same time as actually doing the research?
Yeah, it is a great question. That's what I was thinking of, that exact same slide as well. I actually came in a bit later, so I didn't see those initial conversations and that initial setup, but it was really, really important that they just invest in some of that time in engaging with and recruiting and interviewing various local actors. Everyone on that team, of the 5 social scientists and maybe 10 or so community liaisons on each, so that's a total of about 25 staff, every single one of them except maybe 2 were born and raised in that community. Mm-hmm. And so I imagine it took some time to establish those relationships and to start working with those people and to know who is available for this type of work. But some of them even came on later on, a few months or even a year or 2 after the trial had started, because they had that experience. So it's that idea of always evolving and being iterative. I think that initial startup is definitely going to be the big challenge, but I think if you have that investment in mind and recognize that importance, then you can make it happen, right? There's always going to be some lead up and build up time in order to implement a research program. So you just have to work that into it while you're waiting for protocols, while you're developing the resources you need. You can start building those relationships with people in the community.
Yeah. So there was actually just a great comment that's, I think, a great way to end, which is communities are a diamond field for effectiveness. They must part of planning and implementation for buy-in. There is no way we can do this without communities. And I think a big takeaway from this webinar, at least that I got, was this idea that yes, research is moving rapidly, but not so rapidly that we cannot take the time to invest. I think Zhao really brought that home with the idea that you can still plan, you can still create systems, you can still build teams, even in an emergency, and community may be more important than ever. So I do want to wrap up. We will be sharing this recording, and also, like I said, developing a Q&A with some of your great comments and questions that we will circulate as well with the recording. But we will also be posting it on this platform called engage.avac.org, where you'll be able to find the community of practice piece. And we really encourage you to go there and continue these conversations on the platform itself. There's a lot of really great ideas. And we will also, some folks ask for some resources, so we will be probing our panelists to see if we can get some of those resources that you asked for. Melissa, any final thoughts from you?
Yeah, just to say thank you so much to our panelists for availing yourselves and sharing your experiences and lessons learned with us. And thank you so much to everyone who also attended the webinar, and to the great questions and comments that have been posted in our chat. It's been such a great conversation. We will see you next time.
Yes. And welcome, and have a great afternoon, great evening, great day.
Thank you very much.
Thank you all. Bye-bye.
Bye.